Okay, so for Unit 4, PowerPoint 1, Part B, we're going to switch gears a tiny bit. And we've talked about some of these things before, but this is kind of the lab experiment that goes along with which drugs to give a patient and how much or how little. So there are two different tests in the lab. We would have done the Kirby-Bauer, and we'll do some rendition of it in the weeks to come. So the Kirby-Bauer test is to determine which drug to actually give a patient. And then there's something known as an E-test, and this is to determine how much. So if you take a look at the Petri plate up here on the top, the terms that are usually used are susceptible and resistant. If a bacteria is resistant to the drug or susceptible to the drug, that determines how well it is or isn't at killing off the infection. So if you take a look right here, these little white tabs actually contain antibiotics. And these antibiotics are at set amounts. And what you do is you take a Petri plate and you completely swab it so that it has a full lawn of bacteria. And then you place these little antibiotic tabs onto them and you grow them up in the incubator, and you're looking to see what type of zones or no zones are actually on the Petri plate after the incubation. For example, in this case, you wouldn't want to give this particular drug to the patient because notice the bacteria almost grew right over the pill. That means it is not fighting it off. The larger the zone of inhibition, the more effective the drug is against fighting off the bacteria. So in this case, notice this large zone right here and this large zone, these two are the most effective. You wouldn't want to prescribe either of these two to the patient, although this guy right here, and this one's also good. So as a physician, it might be worthy or worth it to try to give a patient this type of drug where there's a nice zone of inhibition, but you didn't right away, let me just write this out for you, there's a zone of inhibition, but you didn't right away go for the two drugs that created the largest zone because you don't want resistant issues later, and you in fact want there to be a stronger chemotherapeutic agent to give a patient if they were to have a more serious but similar type of infection. So again, this test above is the Kirby-Bauer, which tells you which drug to give a patient. Now on the other side here, we have something known as the E-test. This tests for something short known as MIC. MIC is essentially the minimum inhibitory concentration. In English, it's the least or lowest concentration of the drug that you can give to the patient that it's still effective in fighting off the infection. So if you take a look at this Petri plate up here, all of these strips contain a specific type of antibiotic, and it's at different amounts at each leveling. So you actually purchase these. This is not something you make in the lab. And then the larger the zone right here, you would know that whatever concentration you're looking at this area is a lot more effective than, say, this area where the green is showing the bacterial growth. That looks like Pseudomonas aeruginosa on that plate. It's not killing it off. So you would do these two tests in conjunction with one another. The Kirby-Bauer will tell you which test or which drug you want to give them, and then an E-test will tell you how much of that drug you want to give to the patient. So if you take a look right here, you can see there is a nice zone of inhibition here and another decent zone right here. But notice this particular drug has no zone, which means that the bacteria is completely resistant to that antibiotic. That would not be good to give to the patient. Whereas these two that I circled originally, it is susceptible, meaning that it will in fact kill off the growth of that pathogen causing the infection. This on this side is the Kirby-Bauer test. On the other side, you're looking at the E-test, which is again helping determine how much or what dosage of the medication to give to a patient. So when you do drugs in combination with one another, there are some things that you are looking for. The two terms are one's on the bottom, which is synergy, and the opposite is, hold on, let me spell this right, antagonistic Oh boy, that's definitely not spelled right. One moment. Okay, so you have synergy, and the opposite of that is, all right, that's right, antagonistic. So if a drug has synergy or synergistic properties, that means they work better with other antibiotics. So take a look up here. You have these 3 white tabs contain antibiotics, and notice that the zone originally of inhibition would have been right here. And this one may have been, that looks like the full circle right here. But when you had the 3 medications working together in conjunction with one another, it created a big, large, huge zone of inhibition, which means those drugs are synergistic and working together. On the other hand, the opposite of what I was trying to spell before is antagonism or an antagonistic drug interaction. So here, this would have probably been the zone of inhibition. And for this antibiotic, it's right here. And notice here, the 2 are working together. So these 2 drugs are friendly with one another. But then, if you take a look here, there's absolutely no zone of inhibition, and it essentially started to shrink. So this antibiotic working with this antibiotic is actually an example of antagonism. So, assuming we were staring at one another in class, I would ask you if this is synergistic or antagonistic, and hopefully you would see that in this case, one is resistant and one is susceptible. So therefore, this is an example of antagonism. Oops. Sorry, spelling's not working for me today. Antagonism in drug usage. So this drug is not working well in combination with this drug. So when we talk about drugs and we talk about different medications, you also have to look at the side effects because there are many of them. So some side effects of taking, especially long-term medications, are. So one of those side effects, and a very big one, are damage to the kidneys and liver. My mother, for example, takes Lipitor for cholesterol, and every, I want to say 4 to 6 months, they do send her for a blood test to check both her liver as well as her kidneys to ensure they're not being damaged. Another side effect would be if someone has allergic reactions to the medications. We'll skip one for a second. Resistance is also a big deal. And please remember, we had mentioned this in a previous unit, that antibiotics don't induce mutations. They essentially select for them. So they don't cause them to occur, but select for them because we are taking antibiotics in large numbers and often when they're not needed. So one side effect that occurs I want to talk about, because this will come up in the second PowerPoint for Unit 4, is when somebody has a superinfection. There are 2 other names for that, which are opportunistic or secondary. Many of you may have heard that when you take penicillin, and we did discuss this in lecture once, I think I was surprised that not more of you had heard of this, but they often say to take probiotics because it does do a number on your stomach, going back to that bacteriostatic versus bactericidal drug groups. And by taking the probiotic, you are replacing the healthy normal flora bacteria that should already exist. So in the case of a superinfection, you are taking long-term antibiotics such as penicillin, and it allows for certain bacteria to colonize. Colonize is like a biofilm. So Candida albicans is essentially a yeast infection. So when you have a yeast infection while taking penicillin long-term, that is referred to as an opportunistic or secondary or superinfection. A large example of that is Clostridium difficile, or short, it's known as C. diff, and any of you in the healthcare industry have heard it, you've heard of it, you've seen it, and the smell will absolutely never leave your memory. Couple of terms for you. Take a look at these 1, 2, 3, 4, 5 organisms. HA and CA are just 2 terms I'd like you to be familiar with. HA stands for hospital acquired, while CA stands for community acquired. This is pretty prevalent, virally speaking, to what's going on and why you're having to listen to me on a recording. And these 2 together can also lead to nosocomial infections, which are hospital-borne that we had discussed before. So hospital-acquired MRSA is methicillin-resistant Staphylococcus aureus. This is a different strain of Staph aureus than what traditionally exists, to where methicillin-based medications that were once effective are now no longer effective against that particular strain. There's also Versa and Vari, which is vancomycin-resistant enterococci. So this exists in many different forms, and there are all kinds of new names and acronyms that come out as bacteria become more and more resistant to different groups of antibiotics. So please think back to Part A for Unit 4, PowerPoint 1, where we went through the 5 different modes of actions, or the 5 ways that antibacterial agents work. But there's something else that we need to discuss, which is also on your outline, and this is the 4 methods that allow bacteria to resist antibiotics. I'm just going to write resist drugs, but I am talking about antibiotics. So this top picture here is a traditional situation of what's happening. So this guy right here is a bacteria. You as the patient take a drug. It binds to whatever the target is within the bacteria, and it will kill it. This is a typical flow of how an effective drug works against a bacterial infection. But now if you take a look at the bottom, these are the 4 ways that drugs actually don't work. So you need to know these 4 names. So the first one is increased elimination. The second one is drug inactivating enzymes. The third one is alteration in target. And the fourth one is decreased update. So we can start with the first one. This picture also appears in your outline. Please do not mix up the 5 modes of action for antibacterial agents, which we covered earlier, with this, because this only has 4. And these are the 4 ways that bacteria are able to resist the drugs that we take to fight off that particular infection. So number 1, when you have increased elimination, hold on, my pen is for some reason not working. Okay, increased elimination. This works with something known as an efflux pump. So again, the yellow triangle is the drug. The drug goes into the pathogen and comes right out. It never actually has a chance to work. So the first one is efflux pump. The second one is when we have drug inactivating enzymes. So again, the triangle is going to go into the bacteria, but there is some type of enzyme, which is depicted in this little teal colored circle, that attaches itself to the drug and completely inactivates it, which renders it useless. So that is the second out of 4 ways that bacteria are able to resist drugs. The third one is alteration in target. This one, I want you to think of enzymes and lock and key of how the substrate needs to fit into the active site. Well, you have the drug, that orange triangle, entering the bacteria or pathogen, and it does not have an ability to bind to the target area or the target tissue, because think about the shape just simply being different. And the fourth one, which is the easiest one I think to understand, is decreased uptake, which means it never actually makes it in. So you take the drug, but it never gets past the membranes within the bacteria. So these are the 4 ways that bacteria resist drugs. And I can't express it enough to not mix this up with the 5 modes of action that bacterial agents take that we covered in the first part of the PowerPoint, because on your exam, you're going to be asked about them. And it's not going to say list those 5 and list these 4. It's going to ask you to list 2 or 3 of those or 2 or 3 of these. So it's very important that you not mix them up. The simplest way to do this is to draw out the pictures for the 5 modes of action as well as the 4 ways to resist drugs, and draw them side by side when you study them so you don't mix the 2 up. So on the bottom left, it talks about R plasmids are used to transfer antibiotic resistant. Remember, R stands for resistance. Through conjugation, when you had the pili, when we talked about horizontal gene transfer, we talked about plasmids moving back and forth. Well, this is what happens, and these R plasmids is what causes this resistance to drugs in bacteria. Funny, I should mention that, because This picture right here to a point should look familiar to you. So here again we have increased elimination, which is again the efflux pump. We have the drug inactivating enzyme, where the enzyme attaches to the drug, making it not useful. Alteration in target, where the shape changes and therefore it doesn't work. We have decreased uptake, which is the fourth one, where the drug never even has the ability to get into the bacteria to do its job because it doesn't get past the membranes of the bacteria. So if you look at this picture to the left, here it's showing the plasmid. Here's a picture of efflux pump, where antibiotic goes in and comes right back out. You have a degrading enzyme where it stops the antibiotic from actually working. You have an altering enzyme where again it stops it from working. So the purpose of having these two pictures is I would like you to look at this picture and this picture and have a little conversation with yourself of comparing them. Make sure that you're able to draw what's on this bottom picture to the right, on this top one on the left, and when you can compare the two pictures, that truly means that you understand what you're looking at. So how do we limit this resistance from occurring? There are certain ways to do that. One is you maintain the antibiotic levels long enough to kill off the microbe. That means when you go to urgent care and you get a prescription for, an entire regimen, take 2 pills a day for 10 days. At day 5, when you feel better, you don't say to yourself, well, I'm going to keep the other half because I already paid my $30 copay, and then I can keep the second half of this prescription for when I become ill again. It doesn't work that way. You absolutely need to take the entire regimen from start to finish. Let's look at the bottom one, restricting the use of enzymes. It's frustrating when you go to urgent care, you pay your copay, you get an entire visit, and then they tell you, well, we think it's viral, you don't need antibiotics, go home, hydrate, rest, do all of those things, and you keep begging and wanting antibiotics, but the truth is, unless if it's bacterial, these guys are not helpful. So restricting their use is another way to limit resistance. And finally, the one in the middle, it's using 2 antibiotics together to make them more effective. This is like when we were talking earlier about synergy or synergistic relationships between medications. There is something known as Augmentin that most of you with children have definitely heard of. The normal antibiotic given to kids are amoxicillin for a simple ear infection, but if they need something stronger, they're prescribed Augmentin, and then you're told as a parent, ensure that your child has something ingested in their stomach before taking it, because this is pretty rough on their GI tract and often causes diarrhea. So what this is it takes amoxicillin and binds it together with clavulanic acid, which synergistically works to make it a much better antibiotic, but you don't need to take a stronger one. It just varied in a sense, which is why this is another way to limit antibiotic resistance. So now we have to look at what happens when people stop taking the pills early. Okay, so if you look at the x-axis, this is actually days of treatment. Then if you look at the y-axis, this is referring to the number of organisms. All of the colored lines represent what people are doing in terms of actually taking their medications, so where the serum levels are after a drug test. The green line is representative of a patient that properly took all of their medication for the entire 10-day prescription. And if you notice the dotted line right here coming down at about day 5, 5.5, the person would actually feel a little bit better, but by completing the entire regimen to the 10-day period, the illness won't come back. The brown line in the middle is early termination of treatment. So if you take a look at somebody that had a moderately susceptible organism, this is the purple line, and they stopped taking their medications midway at about day 4.5, all of a sudden the number of organisms is on an uptick and starts rising again. So please look through this a little bit so you can see it, a highly susceptible organism. You take the medication, by about day 3, the patient is feeling better, but if they were not to complete the entire regimen of drugs right away, they would have reinfection and we'd be looking at resistance issues. Read over this when you get a chance. It's kind of interesting, and it's ways to stop taking antibiotic resistance. If you don't know what triclosan is, Google it and think about Bath and Body Works, or is it Bed Bath & Beyond? Yeah, Bath and Body Works, and those beautiful smelling things that all contain triclosan. So lastly, a couple little topics is transmission. There are ones that are direct and other ones that are indirect. Direct transmission is something when you get bitten by something or an animal passes it on to you. This can also be known as a vector or animal transfer. There's indirect by fomites, I will tell you what that is, and then there's droplets, which are, think of anything that is respiratory in nature. When you have a fomite, by definition, that is an inanimate object. I remember discussing this a little bit, so it must have been when I talked about the Unit 4 outline. But this is basically the nail that you stepped on that then caused the infection, or the pen that, oh yes, I talked about Favi eating the pen and then I chew it after her and then I give it to Janae, so that would be the fomite, would be potentially the pen. There are 3 different vehicles of transmission, and this is going to be very important for Unit 4, the second PowerPoint, when we talk about the illnesses, because you do need to know how they're transmitted. And the 3 ways are either waterborne, airborne, or foodborne. So waterborne, think of cholera, or drinking water in a third world country, for example. Airborne, which has to do with influenza or how conveniently COVID-19. And then foodborne, like botulism or a food E. coli or Staph aureus infection, when you've ingested food that is actually got toxic levels of bacteria in them. And finally, vector transmission. Always think bugs or other organisms such as a flea, a tick, a rat, or a mouse. Nosocomial infection is, again, by definition, hospital-acquired. You went in to get treated for one thing and came home with a whole new present. One of the most common ways to get a hospital-acquired infection is a urinary tract one. I want you to think of things like catheters, which need to be changed out regularly in a patient that is a long-term patient or has a catheter for a longer term. We discussed this a little bit when things came up with biofilms and examples. Respiratory tract, if somebody has a trach or breathing tube, the surgical site in general, and then of course there are a few others. This purple graph here shows a list of very common nosocomial infections and what bacteria cause them. The big ones are E. coli, staph, strep, and Pseudomonas. For nosocomial transmission, well, how does that happen? A common one is bacteria from other patients. This is one of the reasons that visitors are asked to not come, especially in a NICU, an ICU, or a PICU. There's bacteria, again, from other infected patients, bacteria from equipment that's been contaminated, and this equipment could be everything from the doorknobs, the water drinking, when you are holding on to IV poles walking around, assuming they haven't been cleaned down properly. Bacteria coming in from the outside, that one's a little bit silly. And bacteria carried by insects. Take a look at this for a moment, because it's going to be important for what we do next. This chart up top lists different diseases on the left, and then incubation periods on the right. Right now with COVID-19, they're saying incubation is up to 14 days. So what does that mean? If you come in contact with it today and 6-7 days later you say to yourself, yeah, this is no big deal. I'm perfectly fine and I'm not ill and I'm asymptomatic and I'm aclinical and I'm not feverish and nothing's wrong with me, that's completely dependent on the incubation period. The reason everyone's talking about a 14-day quarantine is because this virus is known to have, or suspected at this point based on data, to have a 14-day incubation. So if you hit day 15 and you still feel fine, you can assume everything's okay if you've been quarantined. But if you're doing a self-quarantine and on day 8 you're like, oh, I feel good, let me just run to the store and then come home, you restart that 14 days again in case you have come in contact with it. So most people think E. coli is the #1 foodborne infection. In fact, it is Staph aureus. Incubation is less than a day. You know that because within a few hours of eating the wrong thing, you've got that kind of figured out. Syphilis, for example, takes 2 to 3 weeks essentially to know. And my most intriguing favorite one to talk about is leprosy. 10 to 30 year incubation period. So this basically means that for a really long time, you have no idea that you may have contracted it. If you look at this chart on the bottom, it starts at 7 days and it goes all the way up to 20 years. Here is my beloved leprosy. It's very important that you always look at incubation periods because you can't compare COVID-19 with leprosy, because what's the incubation for this guy? Approximately 2 weeks. You can't say I licked an armadillo, which is known to carry leprosy, and 2 years later I'm okay. Why? Because the incubation is up to 30 years actually, not just 20. So why is this important? Because I need everybody to understand the answers to questions and diseases or stages of how diseases work. I would normally have you work with your neighbor or your lab table to discuss it, but this time around I'm just going to go through it with you. The x-axis is time period. The y-axis is the number of organisms. There are 5, so 1, 2, 3, 4, 5 different stages of the disease. First is incubation. Here you have no signs or symptoms. The second is prodromal. When it says vague symptoms, this is where you go, I don't feel too great, but I think I'll be okay. Illness is the one where you absolutely know that something's wrong. You have the most severe signs and symptoms related to your illness. For example, if you have influenza, you have the fever, the aches, possibly the sore throat, the hot and cold rushing back and forth. So you have a clue that something's very wrong. Decline is when the symptoms are going away. This is the dangerous one where people stop taking their medications. And finally, you have convalescence, where you have no signs or symptoms and your illness is absolutely wrapping up. So what my question if we were in class would be, what unit of time would I want to write down here? And I hope based on the previous slide, you all understand that the answer is it depends 100% on the incubation period. If we are talking about a foodborne illness, that you've ingested something bad, you could even set this time frame up here on the x-axis using 20-minute or half-hour increments. You can do it by hours. But if you're talking about leprosy, would you want to do days or hours? Absolutely not. You could do it essentially by 5-year increments because it has such an insane incubation period of up to 3 decades. So a couple questions for you, and the answers are all on the next slide. Which stage have the pathogen present? The answer is all of them. Why? Because just because you have no signs or symptoms, or just because you feel better, you are in fact still with that pathogen. During which stages can transmission occur? Simple answer, absolutely all of them. During which stages is transmission more likely to occur and why? This is a bit of a trick question, and the answer is all of them, but technically during incubation. Why? Because just like what you see happening in the world today, if someone doesn't know that they're ill, they're not going to take precautions to stay away from other people. If you know that you're feverish and not feeling well, you're not going to go visit someone who has a new baby. So if you're in the incubation period, you still have the pathogen and the ability to infect others, but you are completely asymptomatic. And at what period would you start to call the term the disease? Again, it's all of them, because the definition of disease is that you are away from the normal, which means something is off. And in every single one of these stages of disease, you have the actual, whether it's incubating or you're getting better at convalescence, you still in fact have the disease and pathogen floating around inside of you. So there are all of the answers. See you next time for my absolute favorite one, which are all of the pathogens for the second part of Unit 4.